mental health today on a scale of 1 to 10, where 10 is great and 1 is not good at all. So just give me a number. You don't have to put in any words. Let's just get a sense of how everybody's feeling at the moment. Great to see an 8. And if you're feeling below 5, 4, that's also okay. Yeah. All right. So for those of you who didn't hear me the first time, let's figure out where we are on the mental health pain scale. 10 on 10. Deepak, I'm impressed. Okay. Great. All right. We're off to a great start then. Okay. So mental health. I see that there are a few psychologists, trained psychologists in our group, but the majority of people here are social workers, and we have a few doctors. We have a few other allied healthcare workers. So let me just first ask you, please feel free to use the chat box or to unmute. What does mental health mean to you? What does mental health mean? What does good mental health mean? Since you've all scored yourselves pretty high. Chat box is open if you want to put in something there. And don't be shy to unmute. To be happy and feel at peace. Okay. To be happy and feel at peace. What else? Mental wellness. Sense of well-being, to be in sync with the environment. I like how everybody's interpretations are a little bit different from one another. Feeling everything goes as planned. Oh. Joyful and stress-free. Okay, so we all have a sense of good mental health, good mental health being basically all of these things: joy, energy, connection, sense of control, all of those things, and feeling high. Okay, so that's what mental health means to different people. And so like you see in the chat box, there are, to different people, it means different things, but I think we can pull a few fundamental, building blocks that everybody shares across the board. And basically what I'm also seeing that mental health is, I'm not seeing anyone talking about anything negative. Okay, so what I'm not seeing there is stuff like the ability to cope with challenges, or that sort of emotional agility that helps you sort of, go through difficult times without getting too rattled yourself, things like that, because that is also a sign of good mental health. Yeah. So now, since we are talking about specifically mental health in the context of palliative care, what are some of the ways in which having a serious illness can disrupt people's mental health? What can illness do to a person's mental health? Okay, depression. And not just the patient. I want you to always remember that in palliative care, the family is the unit of care, not just the patient. So we're also looking at the caregivers, we're looking at the loved ones. Yeah, so uncertainty, mood swings, anger, insecurity. Yeah, so you get the gist of it. Unprecedented challenges. Unprecedented challenges would be the experience. So the impact on mental health, I'm specifically looking for words about that. Yeah. Losing control of various aspects. Yeah. Great. So I'm seeing a lot of very accurate responses. So let's get started. I'm going to just start sharing my screen now. Senior, please tell me if the screen is visible.
Yes, it is, ma'am. It's perfect.
All right. So I also just want to take a moment to acknowledge the fact that a lot of the content in this, in the slides that I'm going to be sharing with you, were created by my professor, Isabel Paul, who for a while engaged with Pallium India, and she did come in and teach specifically this subject. And I've adapted it over the last few sessions to be more updated. Okay, so just a hat tip to Isabel. And let's start with one thing. What is a disease? Yeah, a disease is abnormal. It's an abnormal condition affecting an organism requiring treatment. I want to read that again. An abnormal condition affecting an organism requiring treatment. So here we're talking about diseases, infections, degeneration, degeneration of tissue, injury, trauma, toxic exposure, things like that. If this is a disease, then my question to all of you is, what is illness? Do we use those words interchangeably? Do illness and disease mean the same thing? Is there a difference between what disease and illness is? Okay, so illness is the component that accompanies disease. And what happens there is it's all of those attending emotions, distress, discomfort, fatigue, weakness, dysfunction, pain, which requires management. So illness is, so if we're going to be really, I think, specific, this is the difference between disease and illness. Although in our parlance, we just use it very interchangeably, very often. Yeah. Now, disease, and so basically it's a feeling of being ill. I feel ill. I have a disease and it makes me feel ill, and I feel ill in these ways. Okay. Now, a disease will usually cause illness, but not always. Are there diseases that don't cause this experience of emotional discomfort, of dysfunction and things like that? Are there diseases like that that don't necessarily cause all these things? Anybody? Sini, I can't see the chat box. Is there anything in the chat? For some reason, I can't see the chat box.
Some yes, no are coming.
All right. Okay, got it. Yeah. Okay. So, yes, there are certain diseases that may not necessarily cause this feeling of illness. For instance, if you have high BP and you're taking medication for it, you're managing it. You're not necessarily feeling the discomfort. You might feel it occasionally, but for most part of your day, you're able to function. You're not feeling all those different kinds of distressing symptoms, so to speak, provided it is managed well. Early stages of cancer. Why is it that so many cancers are detected late? It's because we don't realize we have a disease inside us until we have a very dramatic symptom, and then people go and get tested and checked. And by then, in a lot of cases, the disease has progressed considerably. So people can actually have a disease and not even know about it till much later when they get screened for it. Okay. And there is something that is called somatoform disorders. Now, this is a hotly debated subject. This is when there is a feeling of being ill without any organic disease being discovered. So there's a lot of people who experience chronic pain. Sometimes the doctors cannot figure out what the pain source is. And very often then after a while, they'll tell them, oh, it's in your head, it's all due to stress. There's no physical reason for you to be feeling like this, etc., etc. And this, like I said, is a debated subject because, I personally don't think that the mind and body can be so distinctly separated that they don't interact and affect one another. So oftentimes science catches up a little bit later, perhaps. And actually, chronic pain is one of the saddest experiences because, I've known a lot of people who've lived with chronic pain, and after a while, no one believes that their pain is real. And there is nothing worse than not being believed in that sense. And of course, the illness itself affects the disease. How I'm dealing with this, how I'm coping, my emotional state, my inability to even, the fatigue I'm feeling. And fatigue is both physical and mental fatigue. It might actually have it might seriously impact the way my disease progresses. So I don't want to say that this toxic positivity of, when people fall sick, oftentimes they're told, just think positive, you'll feel better, you'll get better. That doesn't work necessarily. But at the same time, emotional distress can worsen the disease in some ways. And just your inability to function normally may hinder your ability to seek the treatment that you might need for this disease. Sorry, Senior?
Sorry, ma'am. It was a mistake from our end. You please continue.
Okay. So Eric J. Cassell in 1978 said, disease then is something an organ has, illness is something a man has, which I think in 2023 we can change that to is something a person has. Okay, so we must address the disease and the illness. Unfortunately, a lot of the times we're only targeting the organic part of the disease. Okay, so many chemo cycles, so many radiation cycles. What are we doing? We're going to attack these cells. We're going to do this. We're going to do surgery. But it's not all the time that we also look at the illness part of it. How is it affecting this person? How is it affecting his or her personhood? What is it doing to them in terms of their mental health and well-being? Mr. Shivkumar, I will come back to you with that question that you've asked in the chat box in a little while. Yeah. Okay. Okay. Now, this is something that some of you might be familiar with. It's called the distress thermometer. And this is something that, we talked about during the pandemic when we were talking about managing our own distress. And so it's a very simple tool. And you just go through each of these. It can be used in pretty much any sort of setting. And if you use it in a palliative care setting or in a setting where somebody is dealing with a physical illness, all these boxes can still be checked. Okay, so now as a result of your illness, are you having any of these problems? Is there a problem with childcare? Is there a problem with housing, with insurance, transportation? Okay, one parent is sick, the other parent can't take the other children to school, or they're relying on a neighbor to take them to the hospital, so on and so forth. So there are various sections here: practical problems, family problems, emotional problems, spiritual, religious concerns, and of course there's physical problems. Now, the more, obviously, the higher the number of yeses, the higher you are on the distress thermometer. So this is just one way of sort of orienting yourself the amount of distress a person might be experiencing as a result of their disease. Okay. Now, this is, I find, a very interesting concept, and this is a way of framing it. There is something that we call the window of tolerance. Now, what is the window of tolerance? The window of tolerance is this, the gray area. Okay, when you're within your window of tolerance, all of us, that is when we're able to feel a sense of safety. We generally tend to be calm, alert, empathetic. We're able to solve problems with clarity. We feel in control of things, and we're able to engage with other people and so on. And there's this level of curiosity, creativity, so on and so forth. Now, the line that you see here, the white line, all of us have ups and downs in our lives. Okay. And usually these are things that we can pretty much handle well within our window of tolerance. Then imagine there's a disease diagnosis. And what happens is that suddenly the emotional state oscillates upwards. Upwards is hyperarousal and escalation. So when you start feeling threatened, you're not feeling safe anymore. And then you're absolutely sure, I am not safe. Yeah. So you might feel this, I feel threatened, when people first start detecting symptoms that are not going away. They're going to doctors. They're not figuring out what is wrong. So they might be feeling threatened then. But then they get a diagnosis, and it is a serious life-threatening condition. You are in this, the initial shock might actually take you to this zone. Now, there are various behavioral aspects or emotional aspects associated with this hyperarousal state. This is where your sympathetic nervous system is activated, and there might be panic, that might be exaggerated startle, like every small thing is like scaring you, anxiety, hypervigilance, intrusive imagery, negative thoughts, restlessness, all of that. Now, typically, when we go through a period of hyperarousal, we have a little bit of a crash after that. Okay, so if you've been working really hard to meet a deadline, or you've been working through a crisis situation, you're staying awake, somebody is sick, you're taking them to the hospital, etc., usually what follows after a period of hyperactivity is a period of a slump, where you might be feeling exhausted, a little bit disoriented. You might have these sort of very flat affect, not really wanting to talk to too many people, so on and so forth. Now, the more frequently these crisis points hit, the higher we rise into hyperarousal, and the lower we fall into hypoarousal. Okay, and this, when there is a serious illness, these crises tend to come soon, one after the other, and after a while the person does not remain within the window of tolerance for very long. And so where earlier they could respond to something with calm, composure, they're suddenly, they're not being able to do that. Now, I'm sure all of you at some point have experienced this, when, small things are irritating you, like you're easily irritable, you snap at people, or you don't want to talk to anybody, or you feel you just want to go and sleep, you don't want to engage with anyone. So that is when we are not in our window of tolerance. And what disease will do, and what illness will do, and this repeated stress and trauma that accompanies disease and illness, is that slowly that window of tolerance gets narrower and narrower and narrower. Okay, and so this is also how emotional states can affect your physical states. Okay, so this is you can read more about the window of tolerance framework. I mean, there's plenty of literature out there. Okay, now when you're attending to someone, you need to also assess which state they're in and which state you're in. Now, if you're in a hypoarousal state and they're in a hyperarousal state, it's not going to go very well. So there has to be an element of assessing yourself. Where am I feeling distressed today? Am I able to go and meet a patient who has been just given terrible news? Am I in a position where I can hold that space for that person and not maybe respond from a place of anxiety or say something that may not be the right thing at the time? So there's always that self sort of assessment that is also important. So do that distress thermometer for yourself as well. Okay. Now I'm just going to quickly ask you, for those of you who are psychologists, especially, this I think should be far easier to answer. What influence our psychological responses when we are in a crisis state, or when we're in a state where we're not well and we're grappling with having a disease? So one could just be developmental issues. And we go through different developmental stages in life, and we learn different skills along these different developmental stages. We learn different problem solving skills. We learn we cross physical milestones, we cross cognitive milestones. Sometimes there might be developmental issues associated, so that might impact on how you respond psychologically when it comes to a crisis. What does the disease mean, and what is its impact? For example, the breadwinner has a life-threatening condition. What does this mean? It means the whole family is now in financial dire straits. Okay, the youngest child has an illness, and it's a life-threatening illness. What does it mean for the family? There's more existential and spiritual distress over there. So there are different things. What does the illness mean, and what is its impact on the person and their family? What is my coping style? My coping style is to reach out to my friends and my family and have open communication and try and discuss things in a way that is, going to help us arrive at decisions together. Somebody else's coping style might be to just become closed and not talk to anybody, become withdrawn. Some people might just go into, might become very emotional. They're emotional thinkers. Some people might actually go into very rational thought. So there are different coping styles that people have, and that largely also determines what your psychological response is going to be. What is the disease's impact on your sense of self? What is the disease taken away from you? Okay, so like I had said earlier in one of my other sessions, if I were to ask you who you are, many of you are going to define yourselves by what you do, what roles you play professionally and personally. Now, if the disease has impacted me in a way that I can't look after my children, and I was their primary parent, then that's my impact on my sense of self. Oh, I'm not being able to be a good parent anymore. It could be a disfiguring disease. It could be a head and neck cancer that is very disfiguring. And that makes me want to isolate myself and socially withdraw, because, I can't bear to have people look at me in this way. I don't want people to pity me. So impact on your sense of self. what kind of relationships are present in your life at the time. And of course, that is a very important aspect which we've talked about in in the genogram and in the eco map and things like that. What are the other stressors in my life? It's not like once illness hits, all the rest of my life is on hold, right? We still have the other life where we already had stressors, and now we have this additional one. So what are those stressors? What are my spiritual resources? And like I said, it's not just religion, it is what brings me meaning, purpose, connection, hope, things like that. And what are my economic circumstances? That will have an impact on my psychological response. If I'm being hit by a disease that requires very expensive treatment at a time when I'm already doing financially, if I'm already in a financially challenged situation, then obviously it's going to hit me in a very different way from someone who has the resources available to them to access the best doctors, the best healthcare systems, and so on. And this is a very underrated one. What is my relationship to my healthcare providers? What is typically the healthcare relation? What is typically a patient's relationship with healthcare providers, in your opinion? I'm just going to stop sharing so we can interact a little bit with one another. Typically, how do you think a healthcare provider relationship with the healthcare provider impacts somebody's mental well-being or psychological responses? Is there an impact? Yes, Neha. Uplifts hope. Okay. Reassurance. So, okay, these are, you're talking about a good relationship with healthcare providers. Yeah. What else? Can you give me an example of like an unpleasant relationship with a healthcare provider that has impacted you in some way? A lot of times there is power play. You're absolutely right, Neha. Okay, let's just take a minute. Can we get some experience sharing? Have you had, and it could be a good or a bad experience. Have you encountered a healthcare provider that has impacted you either positively or negatively?
Participants can definitely unmute and interact.
Post-lunch slot is a dangerous slot, Shri.
Not for us when you are there, ma'am.
Oh. Thanks for the encouragement. Okay. I'm assuming everybody's just had great relationships with healthcare providers. Okay, so oftentimes, there is a power play like Neha was talking about. And that power play can be very scary for a person who is accompanying a loved one or who is sick. And I remember my mother was a very fierce woman, but when it came to the doctor, she became very diminutive and very subservient. And I saw a side to her which I didn't see before, and I thought, wow, this is interesting. And she came from that generation where doctors were basically people of a different caliber, right? In fact, it's a very interesting, I think it was Dr. Raj who once jokingly said to me, and I don't think he was really joking. He said, see, in the hierarchy of things, there is neurosurgeons, cardiovascular surgeons, oncologists, neurologists, God, and then everybody else. So that's the hierarchy of things. And sometimes we treat our healthcare providers in a godlike way. And what happens there, the communication channel does not become two-way. It becomes a one-way channel. We're afraid to ask questions. We're afraid to clarify our doubts. So those kind of things can really have an impact on how I feel and in terms of well-being. Yes, Jayanta?
Yeah, ma'am, though it is very sensitive, but I wanted to share.
Please.
Am I audible?
Yes, you are.
My father had Alzheimer's, and my mother was the primary caregiver initially. Then they were in our ancestral home. Then I shifted them back to my place in Kolkata. So I found out that the relationship that between my father and mother was very bitter. But luckily, my father had a good rapport with my wife, so she managed both the ways. But I was very confused that how come this can happen, because I have known since my birth that my mother was the caregiver for the whole family, my extended family and all that. So this happens, and it really becomes very hard to cope up with. And I just shared it to just get some insight that in such situations, my father had passed away last 3 years back. So if such incidents recur, how do we address it?
Instances like, can you just be a little bit more, can you expand a little bit more on that, Jayanta? What kind of
Instances like that, that my father was actually become very abusive on my mother, and which was very unnatural of his behavior, initial behavior. And this happened only after this Alzheimer has registered and it advanced to a certain stage. And actually, he was a very logical person. We have found him, and he was actually the guardian of the whole family. Everybody looked up towards him. These changes in relationship, it's very hard to fathom how these changes came up actually, and how to cope up with these changes.
Okay. So, Jayanta, firstly, thank you very much for sharing your story with us. I think it's very, it takes a lot of courage to come in and share something so personal. So, thank you for that. And I'm also very sorry about your dad and basically the difficulties that all of you experienced. Diseases like Alzheimer's, and especially all these conditions that I think have neurological impact, and causes these kind of changes in behavior and even personality traits, they're very, very difficult. I can only imagine how difficult it was for you. I don't have a straightforward, answer to this, because every family is different. But I think to a large extent, some sort of psychoeducation around what to expect around these illnesses, that the fact, I mean, these diseases where it can cause this. And, it's not that the person that you knew all your life to be a particular way is suddenly a different person. Sometimes the organic basis of the disease itself can cause those changes. And it's very, very difficult. I know it's easier to say it than to experience it, but to understand that this is it's nobody's fault. Because one of the biggest things I think people hold on to is that sense of, guilt of, did I not do anything? Did I not catch this in time? Did I not do enough? And I feel like these conversations, if they're not had while the person is still around, it causes a lot more guilt and distress later on as well. So I know I'm not answering your question very accurately, but I would say that it's also the role of the healthcare providers like us to really have those conversations with the families on a regular basis, because they really need that support at that time. And it's not easy to reach within the family to have that comfort, because everybody's experiencing that kind of suffering together. So it's really important for healthcare providers to engage on a consistent level with caregivers, especially at time. And diseases are like, and I know there are doctors here, so you can please correct me if you think that you want to add something more. I think the neurological diseases can be particularly cruel to the family. Also because of their prolonged nature, because of, the personhood just being gone. And oftentimes it's harder on the caregivers than it is on the patient itself, because they're not really oriented to what's happening. There is a new field, Jayanta, of neuropalliative care that has come up. And Dr. Roop Gursahani from Hinduja Hospital, he has sort of spearheaded it in India. There are courses that are coming, that for medical practitioners that have come up, but also we will be working with them to come up with some of these issues, because communication, coping, things like that in neuropalliative care is a little bit different from other diseases like cancer and things which don't, affect the mind in that, or may not affect the mind directly at that point. I mean, of course, cancer can also do that. But so I'm at least I find comfort in the fact that this is a field that is now being studied. It is being contextualized to India. So we can get more info. I'll be happy to connect you with Dr. Roop as well, because I know that this is something that is very, very close to his heart as well. So is it okay with you if I move on? I can see there's
Yeah, ma'am, thank you so much. And actually, I'd love to get connected to these people also, so that I can work further in the community.
I'll be happy to. There's also an ALS support group in Bombay, for those of you who are interested, which is made up of people who are caregivers, healthcare providers, and community people who are just interested in supporting families where people have had ALS, which is, again, a very, very difficult disease to live with. Shiv Kumar, thank you for your share as well. And that's a lot to unpack. I will, if it's okay with you, I will come back to that in a little while. Thank you again. Thank you, everybody who's actually trusting us with these shares. Okay, so just in the interest of time, let me just move forward. Okay, so some of the common illness related mental health conditions seen in palliative care are anxiety, complicated grief, depression, delirium, and trauma. I am not going to go through complicated grief, delirium, and trauma with you at the moment. There's just too much to cover. We will be talking about complicated grief in a specific session about grief, and we'll get into that in more detail. Okay. But very quickly, I am going to talk about some of the most common things, which is, of course, anxiety is very, very common. And anxiety is usually an intense, excessive, and persistent worry and fear about everyday situations, okay? And if you are going through a stressful situation, like for some people, public speaking is very stressful, or you're going for an exam or whatever, it is perfectly normal for you to have anxiety. Then there's nothing wrong with it, because it's a perfectly normal response. It actually activates you and makes you a little bit more alert and things like that. But it becomes problematic when you're consumed by these feelings. And it's getting in the way of your day-to-day life, and it's happening too often, and it's just, you don't know where it's coming from. There's no stressful situation, it's just a regular day, and yet you have this anxiety about everything. But so anxiety is a very common condition. Now, in palliative care, specifically when you're living with chronic and advanced illnesses, it can be associated with increased symptom burden. Now, what is increased symptom burden? Earlier, I had only, I had some gastrointestinal disturbance. Now I have pain. Now I have fatigue. Now I have, I can't sleep. I've got insomnia. So as my symptoms are increasing, or as my symptom burden is increasing, I'm getting more and more anxious. Because does it mean that the disease is spreading? Does it mean that the disease is getting worse? Does it mean I have to take more medication? So those kind of things. So increased symptom burden can cause anxiety. Medical procedures and interventions. How many of you here love going to the dentist? Like it's a source of, yeah, I can't wait to go to the dentist and get my tooth pulled out. Anybody? No. So medical procedures can cause that. And I think for me, the most common thing is that getting to that dental appointment, because, for other people, it's different things, right? But for somebody who's living with a serious illness, those medical procedures can actually be very traumatizing. And just, the anticipation of it causes anxiety. Oh no, I'm up for my next review. It's happening next week. And from now itself, I'm starting to get worried about what the reports are going to say, what the doctor is going to say. And is it going to be a painful intervention? This time when I go for chemo, am I going to be vomiting for the next 2 days? Those kind of things. Okay. Decreased function on multiple domains. So as disease progresses, people might lose certain, physical function, their mobility, their physical independence. Cognitively also, it might affect them. They might have trouble concentrating. They might have memory lapses. And please know also that medication can also cause some of these side effects. And so that might cause even more anxiety. The socioeconomic impact is a no-brainer. That is something that I'm sure is going to cause anxiety, irrespective of whatever kind of illness or disease it is, because today healthcare is expensive. Unless, a lot of healthcare is expensive. Of course, you have things that are subsidized, things that you can access, but by and large, having a serious illness is a very, very impoverishing experience for a lot of people. Loss of roles and autonomy, I think we've talked about this. And the minute somebody gets diagnosed with, oh, I missed some interesting chat. Okay, so, oh God. Okay, so I'm seeing some of those messages now. So what I was saying is that the minute somebody is diagnosed with a serious with a serious illness, we immediately make them the patient. After that, it's like, no, we'll get that glass of water for you. You don't get up. I'll do the cooking. No, you stay. So it's out of love, but we make them feel even more diminished. We start making decisions for them. We start making decisions about them. Caregivers and doctors will get together and make a decision about the patient. And that is a huge loss, that loss of autonomy, my own decision-making ability about myself, my ability to control where my life is going and what I want. And so that loss of that role as a decision maker, the loss of the role as a mother, a parent, a student, a teacher, whatever it might be, all of these things cause anxiety. And it can be, I mean, I cannot stress how much anxiety comes from losing that sense of autonomy and control. Okay, information gaps. I would say this is one, I would have actually put this right on top, because not knowing all the information that you need, those of you who understand Gestalt psychology, we talk about the fact that the whole is greater than the sum of its parts. And also what we do is, as human beings, psychologically, we are oriented to filling gaps in information, and filling those gaps with our prior knowledge, information, experiences, whatever else. So we form patterns where there are none. I mean, or where we see there might be a pattern. So if there is gaps in information, we typically fill it with, our imagination. And our imagination is, of course, it is influenced by many things. So information gaps, uncertainty, so if I go to a doctor and I say, okay, if I take this medication, then, how much time is it going to take to work, and how soon will I get better? And if you get an answer like, oh, we can't really say, that's anxiety inducing. Okay. Decision making and determining goals. Even making decisions is stressful. Now you have these different treatment options. If you do this, then these are your chances. This is how it's going to respond. Alternatively, you can do this, but it's much more expensive. There are these decisions where you have to maybe do something which is experimental. Now, also taking into consideration that these decisions come at a cost. It's going to cost me to do these various interventions. There was a family that, before they got referred to palliative care, they were fairly well off. But there was no father. The mother was sick, and it was the son and the son's wife that were having to make her medical decisions for her. And the thing is that eventually the decisions came down to the financial cost, because there were interventions that they could take which would take about 8 months, but it would completely drain their savings. There were interventions that could be done in 4 months, but but the outcomes were not great. So having to make those decisions on a regular basis is very, very anxiety inducing. And also to determine what goals. Okay, where do I want to be a month from now? Where do I want to be, a week from now? Things like that. And of course, the isolation, not just the isolation of physical isolation, the emotional isolation that a patient goes through. Because you might have people walking alongside you the whole time, but ultimately it's you living with that disease. And that can cause a lot of isolation. Guilt. I wish I had gone to the doctor sooner. I wish I had listened. I wish I had stopped smoking 20 years ago. I wish I had never started smoking. I wish, this had not, maybe this is happening because I didn't do this. So that kind of guilt is also very anxiety inducing. And of course, future, what's going to happen in the future? The loss of a future, the loss of the idea of a future, if it's a very serious terminal condition. And those are also anxiety inducing. So how do we counter it? Firstly, I would say the most important thing is information. And I think this cartoon is quite accurate, so because a lot of the times this is what happens in other ways. There's no easy way I can tell you this, so I'm sending you to someone else who can. Or there's no easy way to say it, so I'm not going to say it at all. So information is very important. First of all, don't start by giving information. Listen. What do they know? How much information do they have? Okay. Understand what they know. What do they know? I have idiopathic interstitial lung disease. I know what I have, right? So does that mean I know what I have? Yes or no? I have third stage, retinoblastoma, whatever. I know the name. Does it mean I know what I have, or how exactly it's going to impact me? Yeah. Okay. What do they understand of what they know? This is what I mean. Google is the best worst enemy these days. It's true. Dr. Google is the most dangerous doctor. Please don't go to Dr. Google alone. Okay. So what do they understand of what they know? I know I have idiopathic interstitial lung disease. What does that mean? And I think I've said it here before. I take this example because it was what my mom had, and it was an incredible pulmonologist who actually broke it down into lay terms and explained what the organic, what the biology and the workings, the mechanics of the disease itself are, and how it's likely to progress, what we can expect in terms of impact on her sense of well-being, her independence, her mobility. So it really gave us time to prepare for all of these things. And that's when you know that they really understood what the disease means. Elicit unstated fears and worries. Tell me what is worrying you at this point, now that you know all of this. And for different people, it's different things. For some people, it's the economics. For some people, it's the pain, the suffering, various things. For some people, it's just practical issues. I don't have a caregiver. I don't have anybody who can stay at home and look after this person, because if I stop working, I can't pay the medical bills. So I need to make decisions about those medical interventions as well. Okay. Now, this is an important one: medical anxiety versus death anxiety. Too often I come across people who say, please don't tell them that this is a terminal illness. Why? Because it'll take away all their hope, and it's going to make them nervous and scared. It'll break them, things like that. And well, I'm not going to, take away from the fact that very often the caregivers do know the patients the best because they are relatives or loved ones or whatever else it might be. But oftentimes because we're such a death denying society now, where it's not comfortable to talk about death and dying, it is inauspicious, it's abshagun, it's all of those things. It really closes the conversation. But our assumption is that everybody is afraid of dying. So the thing is that, yes, some people are afraid of dying. But if you dig a little bit deeper and really speak with somebody, understand what their fears are, a lot of the times we find that they are afraid of how they will die. Are they going to suffocate? Are they going to be in excruciating pain? Are they going to lose their senses? Are they going to be, delirious? Are they going to lose bowel control? Are they going to bleed? Very often, these are the anxieties that are accompanying, that's playing on their minds. And that is medical anxiety. It's not death anxiety. So please learn to make the distinction between the two. Because if somebody then says to you that, yes, this is what I'm afraid of, you then have a conversation that you can reassure them through and say, you know what, we will make sure that your pain is managed. We have means to control your breathlessness. Now, in my case, in my mother's case, 22 years of my palliative care training kicked in for just one conversation, because it's very different when it's your own person. And I remember her, even after having an oxygen concentrator at home, and we had these 4 World War size, those oxygen tanks at home and everything. She asked me, am I going to get better and things like that. Eventually, we had a conversation, and I asked her straight up, I said, what are you afraid of? And she said, my mother died of the same thing. So my grandmother had died of COPD, but at the time they didn't have the interventions they needed. So it was a very, very, she suffered a great deal. So she said, I don't want to go down the way Nanu went. And I said, okay. So I said, but what is the difference between what happened to her and what's going on with you? And she thought about it, and she said, well, this time we have oxygen support. We have doctors who we can talk to. We're getting medication. We never had morphine. For Nanu, I have morphine. So I said, yeah, you see the difference. And so her anxiety came down considerably because I was able to assure her that you will not suffocate and be breathless the way, my grandmother was. So that actually went a long way in reducing a lot of her anxiety. So please make the distinction between medical anxiety and death anxiety. And of course, death anxiety does exist, and that's a conversation we will have another time. Okay, now, goal setting, short term, medium. And here's the thing. Who here thinks you're going to live forever? Anyone here thinks you're immortal? Anybody? I don't see the whole screen, Shri, but if you're seeing any immortal hands going up.
I can't see any hands going up.
Okay, so it's safe to say we all know that the inevitable consequence of living is dying. And but people tend to just want to put everything in the broad perspective, right? We are not going to talk about this illness because it is so serious. We don't have to talk about the end game. We can talk about what we want to be able to do tomorrow. We can talk about what we want to be able to do next week. So setting these short and medium goals, we can set long-term goals as well, but I would say focus on the short and medium goals, because what that does is also it reorients hope. You're not hoping to live forever, but hey, I'm hoping to be able to walk to the bathroom by myself next week. Yeah, we can work on that. Okay, so those kind of things also go a long way in really sort of helping people compartmentalize, taking it a day at a time. Problem solving through shared decision making. We will be talking about this more in our communications class, but typically we don't have shared decision making in our communities, in our settings. Very often it's a very paternalistic approach. So there is there are different levels. So one is that me just giving you information. One is me giving you information with recommendations. So this is the treatment for this disease, is the information. This is the treatment for this disease, and this is what I recommend because this has got a high success rate. That is information with recommendation. And the third is, which is what shared decision making is information with recommendations, taking into consideration the other person's values and preferences. This is the disease, this is the treatment, this is what I recommend from my past experience, but tell me, is it something that your family is able to align with? Is it affordable to you? Is it something that you're willing to take a risk of these side effects? Do you have a caregiver who can be with this person through this kind of a treatment regimen? So that is shared decision making. So so that's really important. And what all of these really do is restores a sense of control. And restoring a sense of control to somebody who feels like they've lost all control of their life is one of the best things that you can do for them. And this is, again, something I see a lot in children with older parents. And this is somebody who's been head of the family or who's been a decision maker, and suddenly there's no control. They've lost all control of their lives because it's been taken away from them. And then I hear these children saying, God, he's so bullheaded and so stubborn, so difficult, doesn't want to come for any of these treatment options, doesn't want to do this. It's because they're trying to assert control in the only place they can, in their zid, or in their will. So if somebody is being extra stubborn and stuff, try and examine whether their sense of control has been taken away from them. Because if that's happened, then the chances of them holding on to whatever little control they have is going to be higher. Okay, you have to restore a sense of safety, because illness and disease can really threaten your sense of safety. And firstly, for that, you have to understand what safety means to them. For me, a sense of safety is the fact that I can pick up the phone and call my doctor and ask them for guidance, for questions, and be treated like a human being rather than just another statistic on a doctor's roster. Assurance of care. Yes, no matter what happens, I assure you will get the best quality care. That is a sense of safety, that yes, I'm in good hands with this team because they will act in my best interest. Identifying social support. Again, this keeps coming up in practically every module that we do together, but identifying social support is really important because the safety net has to be both inside and outside of the hospital. Access to caregivers and healthcare teams. And access, I mean, this might seem like a very obvious thing, but not everybody has the kind of access that they need. And whether it is to caregivers, and the number of families struggling with just having a caregiver at home is really, really, I mean, it's incredible, those numbers. Frequent clarifying conversations with healthcare providers, with multidisciplinary teams. Today, it could be with the social worker. Tomorrow, it could be with the nurse. Day after, it could be with the counselor. So frequent clarifying conversations, and understand that people need to have these conversations frequently and repetitively, because disease and illness is a very emotionally volatile time. And I may not be able to absorb all the information all at once if I'm very stressed out. So I might ask you the same question the next time we meet. Don't be irritated. Answer the question. And involving people in the goals of care, rather than telling them what their goals of care should be, ask them what is important to them. And that is really okay, I feel safe in having this conversation. Okay. And this, I cannot understand. We cannot do any of those things if the person is having severely distressing symptoms. Somebody who is breathless, who hasn't slept properly in months, who is fatigued all the time, is not going to be able to cope properly. So you have to make sure that a person who is in excruciating pain is not going to be able to sit through a shared decision-making session. They can't think straight because they're in such blinding pain. So please make sure there is adequate symptom control before you try and bring in all these psychological interventions, because otherwise it's not going to go anywhere. Okay. And now, how to, very quickly, just some tips. How to communicate with someone who's got anxiety regarding their illness. Firstly, you have to reassure them that anxiety is common, especially amongst people receiving palliative care. Acknowledge their feelings without judging or minimizing their feelings. Yes, I can see that you're really distressed. Rather than saying, don't worry, we'll take care of you now. See, Mrs. Sharma over there, her disease is so much worse. So don't minimize, don't dismiss, don't judge. Ask open-ended questions instead of saying, today you're feeling better, no? I mean, there's only one answer to that. Yeah. Ask open-ended questions. How are you feeling today in comparison to the last time we met? That'll give the person a chance to really sort of expand a little bit more on maybe not just their immediate physical symptoms, but also on their life circumstances, which contribute to their feeling of total pain. Allow pauses in conversations without rushing to fill them in. It took me a long time to master this skill. I'm sure it's pretty obvious that I talk a lot. So for the longest time, I had a problem with awkward silences or silences. And we're rushing in to fill the silence. There is profound therapeutic value in sitting with somebody in silence till they are ready to share or talk. It doesn't have to be awkward. So learn to cultivate that sense of being able to sit in silence with somebody, just offering your presence. Repeat or rephrase what the person told you to show that you understand what they're saying. Because also people with anxiety sometimes will stumble over their words, or they might contradict themselves. So it's important for you to rephrase and repeat what they're saying so you've not misunderstood what they're trying to tell you. And use everyday language, no medical terminology. Don't say metastasize when you can say spread. Provide information in the person's preferred language and format. And if you don't speak their language, get somebody who does. It takes time to build a trusting relationship. Just because you're the healthcare provider doesn't mean they automatically have to trust you. Okay? And asking them how their anxiety affects them. What makes it better? What makes it worse? So that helps them also map these trigger points. Is your anxiety worse just before you go to bed? Tell me more about that. Okay? So things like that. Ask them how you can help when they're anxious. Would you like me to be quiet? Would you like me to take you for a walk? Don't presume that you know what they want. Avoid pressurizing them into doing something they're not ready to do. And we are all guilty of trying to make our patients do something that they're not ready to do. Okay, so that's very important for us to remember. Okay, how are we on time? Shri, can I take another 10 minutes?
Yes, ma'am, please.
Okay, all right. So before I move on to depression, Shall we do a very quick, like, can everyone just stand up and take a quick walk around their tables and come back and get some circulation going? Depression is a heavy subject to sit with. It'll also give me some time to go through the chat. So if you're not going to walk around, at least flex your fingers, shake your shoulders a bit, put your feet on the ground. If you're in a place where you can take off your shoes, take off your shoes. Just get some sensory sort of kinesthetics going. Okay. Okay, Geeta, I see that you've left a question on how to make the caregivers understand they're in denial. Shri, can I ask you to please make a note of these questions? I'll come back to them.
Sure, ma'am. Will do.
Like the ice cream conversation. Oh, Nivedita. Okay, there's some great conversation in the chat box. All right, is everybody ready to come back? Quick deep breath in and exhale, and we will dive into depression, which is a terrible sentence, but okay. Now, this is one of the most misused words on the planet. It is used very flippantly, very often. So what we're talking about in terms of depression is not just someone feeling low and sad, okay? Serious clinical depression. Firstly, it's a common mental disorder, which has actually caused it to, be misinterpreted also a lot. Now, persist, I've highlighted some words in red. Actually, can someone else read this out? I'm kind of tired of the sound of my own voice. Would anyone else like to unmute and help me with this? Jayanta, are you going to?
We can't hear your voice though. We could see you that you are unmuted, but
Who, me? You can't hear me?
no, ma'am, for Jayanta. Like I could see him now again he got muted.
Okay, can we have somebody read this out, please? We're running out of time. Yes, Anup.
Yeah, so depression is a common mental disorder characterized by persistent sadness and a lack of interest or pleasure in previously or enjoyable activities. It can also be disturbed sleep and appetite. Tiredness and poor concentration are common.
Thank you very much. Thank you very much. So I want you to actually focus on the first two descriptions. Yeah, persistent sadness, persistent, unshakable. Persistent means it doesn't go away. So that is a hallmark of depression. You don't feel anything but sad and lack of interest or pleasure. Now, I used to like watching TV, don't want to do it anymore. I used to like going for walks, don't want to do it anymore. And this sort of thing just stays there. So that is very different from someone just being sad. Okay, so persistent sadness and lack of interest are two hallmark symptoms. Disturbance of sleep and appetite, tiredness, and poor concentration, of course, could also map to other mental disorders. Now, depression and palliative care. It's a very common thing in palliative care populations, and estimated prevalence ranges from 24 to 70 depending on the disease. So certain diseases actually have a much higher, they see a much higher rate of depression in them versus others. Leads to a decreased quality of life, stating the obvious, may lead to a desire for an earlier death. So suicidal ideation can come in. Very often depression is associated with increased pain and fatigue, reduced treatment adherence, poorer prognosis, and higher mortality in a range of physical illnesses. Now this one, just read the sentence again. Depression and increased pain and fatigue, they can bounce off one another. If I'm depressed, I'm going to adhere less, there's less compliance with my treatment, which makes my disease worse. Okay, and therefore a higher mortality in a range of physical illnesses. So good quality palliative care itself is a key strategy of preventing depression at end of life. If I'm going to give you good quality comfort care, make sure your pain is controlled, make sure your symptoms are in control, I'm taking care of the different things in your life that are possibly stressors, thereby I'm curbing the depression. So good quality palliative care is a good way to prevent depression from actually happening. Now, we will talk about this a lot more in our grief session, but I just want to put this out here because this is a very, very common mistake. Grief and depression are two different things, and grief is very common when somebody is seriously sick. There's anticipatory grief. We will talk about this in our session on grief. But, very often, too often, I hear people saying, patient is depressed. Patient may not be depressed. Patient might be grieving for the hundreds of losses that they're experiencing every day, right? And grief is an adaptive response. Something happens and I'm responding to it. Depression is not. Grief is distress over a particular loss. For example, I've lost the ability to be independent. Okay? Distress in depression is pervasive and it affects all aspects of life. It's not a response to any one thing. In grief, symptoms come in waves. In depression, it's constant. Mood is sad and dysphoric, so it changes, okay? But in depression, it's protracted, constant, flat affect. So in grief, you feel sad, and then you feel okay. You feel sad, you feel okay. In depression, it's just no pleasure, nothing, absolutely nothing. And while we're grieving, we're still able to engage with other people. We still have our interests. Even though engagement might diminish, we still have things that, might give us some pleasure, some comfort, like reading a book or listening to music and so on. In depression, that's not the case. In grief, there is episodic and focal loss of hope, which means that it's very specifically tied to something. And it may change in time and towards a more positive orientation. But in depression, we see this kind of hopelessness that is like a wall that you can't break through. It's just hopelessness all the time. In grief, there might be regrets and guilt over specific things. In depression, there's just excessive feelings of guilt for nothing in particular. And you might see that, when people have just experienced a massive loss, they might have this fleeting desire for death. But in depression, there could be this preoccupation with dying. Okay, so those are just some differentiating factors, but please make this distinction. Don't just label somebody as being depressed, because we do that very often. Okay, now, but the problem here in palliative care settings, we also have some diagnostic challenges. Depression, anxiety, etc. could be underdiagnosed because it's considered to be a natural part of the experience of illness. The guy's got a terminal illness, of course he's going to be depressed. What's the point of going and doing one, intervention for that? Hypoactive delirium. Hypoactive delirium is a kind of condition. Grief, poorly controlled pain can also be misdiagnosed as depression. Okay, causing avoidable harm from inappropriate pharmacological treatment. So if somebody gets labeled as depressed and people are put on antidepressants, it's not a good thing if they don't actually have the depression. Now, there are medications that are used in palliative care or in advanced disease conditions that actually, not in palliative care, sorry, but in, like, say, for example, in chemotherapy and stuff, that actually can induce depression as a side effect. Okay, so please see that whether these medicines are on the list that the person is taking, because this could be the cause of the depression. And lack of energy, changes in appetite, body weight, impaired concentration, sleep disturbances are very common manifestations of medical disease. They don't necessarily mean that the person is depressed. If I'm sleeping a lot, it's because I'm exhausted. Or I'm not being able to eat because the disease has affected my GI tract or my appetite. Doesn't mean I'm depressed. So try and see how the disease is physically affecting the person before you label them with depression. And a lot of us are just uncomfortable with this idea of dealing with someone with a mental health condition. So we don't want to go there. We don't go there. We say, it's not my job. I'd rather just deal with the physical symptoms and the social issues. But I really don't want to get into the space with this person. Also because a lot of us lack the skills and training. It's a very underserved area, mental health, as most of you know. So sometimes we just don't have the bandwidth for it. A very simple way to screen for depression is ask these questions. During the past month, have you often been bothered by feeling down, depressed, or hopeless? During the past month, have you often been bothered by little interest or pleasure in doing things? Yes to either question is considered a positive screen. This does not mean that they have clinical depression, but it warrants further investigation. Okay, so, and please go back to what I had mentioned before, check the medicines, check for disease status and so on. Okay, and the best way to do this is to really interview the person physically. Over a phone is not, I mean, some of us don't have the time, I know, but ideally, best practice wise, it's good to see someone in person, because there's a lot that you get from just absorbing the person's, behavior and movement and things like that, that'll tell you a lot more as well. And you can use the mini international neuropsychiatric interview. That format is available online. You assess for the severity of symptoms, the duration, the impairment, person's past psychiatric history. Please look into that. What could be the alternative diagnosis? Could it be a side effect of medication? And what are the contributory factors? Oh, they've just suffered another loss a few months ago. Yeah. Or somebody else in the family is sick. It could be so many other things. Diagnosed according to the ICD-10 or the Diagnostic and Statistical Manual, version 5 is out. These are basically for the psychologists. These are pretty much our textbooks. Please use validated assessment scales. We don't intuit, just as in medical science, where you need to do certain investigations to be sure. Similarly, for mental health disorders, there are validated scales and assessment tools. Please use them. Because just to say, I've had a conversation with this person, definitely clinically depressed, that is not a diagnosis. That is not a professional diagnosis. And we will not, and it should not be accepted. Use low threshold for treatment, which means if you have a doubt, explore it and treat it. Okay. But again, this is a slippery slope. Be very careful here. But at the same time, it's like morphine. People wait till they are in extreme pain to take it. No, you can start when your pain starts. So similarly, if you have a doubt that somebody has clinical depression or somebody is going through an acute anxiety, problem, then definitely it should be treated. Okay, most psychologists here are familiar with this. What are some of the different psychological interventions? There's CBT, which personally I have veered, well, it works in some settings. It's very effective, of course, but it needs a little bit more of, I think, a humanistic approach in palliative care settings. You cannot do a 12-session intervention and also with CBT, the thing is, with some of these interventions, you don't know the person's disease trajectory. So you'll have to also be ready to pivot with different interventions. Group therapy also helps a lot, especially in terms of like support groups and things like that. But also group therapy here is not just people getting together and sharing their problems. It means having a facilitator who is trained to get them to share in a way that is beneficial to the group, not just a bunch of people coming and saying, I also have this, I also have this, I also have this. It's not that. It's to actually seek ways in which we can feel better and improve our coping skills. Couples therapy also is useful, especially because in couples, we talked about this, very few people go into the sexual issues that come up with illness and disease. And this is very difficult on families and couples. So couples therapy for people where one spouse is sick could really help with the intimacy, with reduced levels of depression and so on and so forth. And supportive psychotherapy, which I wouldn't just say psychotherapy, just counseling of different types is always useful. So I'm going to stop with this, and I've taken up way too much time. Shri, are there any questions that I need to take?
Yes, we had a couple of questions like, should I go from the back to front or front to back this journey? I think we had posted one query from Mr. Shivakumar, referred pain regarding referred pain. Is it same as the somatoform disorders? One question we had parked for later. So would you like to take address that?
yeah. So I just firstly, I'm not a medical doctor, so I cannot accurately answer that question. And that is a question that, see, referred pain is not. I don't know enough about the biological mechanics of it. I do know that referred pain also is pain that shows up in a part of the body that is not directly affected by whatever it is, whether it's an infection, whether it's a tumor site or whatever else. I wouldn't personally, I wouldn't call it a somatoform disorder, because referred pain, there is a site. There is an organic site that is the origin site. Okay, in referred pain, my understanding, again, this is coming with a disclaimer. If there are doctors here who can clarify this, please go ahead. But there is a site of where the source of the pain is. It's just that the pain is showing up somewhere else, and we're not sure of how that connection happened. I wouldn't say it's a somatoform disorder, but if anyone else has a different opinion, please, I invite you to share it.
We do have 6 or 7 doctors joining in for this particular batch. We will wait for them. In the meantime, in the best interest of time, Ms. Geeta wants to know how to make the caregivers understand if they are in denial of the patient's condition.
That is a whole other section on collusion, denial, collusion, all of those things. We will be talking about it in our communications class. So Geeta, if you could please bear with us till then. It would take up way too much time to discuss it now, because there are strategies and techniques involved in that. So thanks, Geeta. Yeah.
Ma'am, may I just put in a query?
Yes.
In my professional practice, it so happened very recently that an old lady, she's of 87 years old, and she suffered from stroke, and she's bedbound. But the decision makers, the people in their family, part of them are ready to go for the therapy and all that. But suddenly the person who actually is bearing all these costs came up and said that, no, she is too old to be any good, so let us stop all the therapy. So as a professional, I just came out from the scene, but it haunts me in my personal space. So how do we challenge these situations? This come up very frequently.
The person who controls the finances controls the decision making. That is the reality of it. And unfortunately, there's not just a power dynamic between the health services and the patient and family, but also within the family, right? If the person who's paying the bills has decided that this is not a course that they can go forward for whatever reasons, I'm afraid beyond a certain point we cannot challenge the decision. It's a terrible thing to say, but if we try and do this with every family we come across, we are also overextending ourselves. And what might happen is we might, what little good we can do with the family, we don't have access to the family anymore, or we don't have access to the patient anymore. I would say good quality comfort care, palliative care is very, very accessible at an affordable rate cost. So if somebody is unwilling to go for expensive interventions and treatments, we can still provide them with good quality and economic solutions through palliative care. So when this is the same, so in my head, it's like a doctor saying there's nothing more we could do, and a caregiver saying I cannot go through with any more interventions. We learn to interpret that as a complete loss of hope. It's not. Palliative care says, no, there's never nothing we can't do, right? So if that's the way the family is going, we have to, beyond a certain point, respect that. We cannot cause any discord, or we cannot challenge that family, because like I said, we lose access to the patient. You can still provide some level of quality palliative care. And I would also say that, having these boundaries, sometimes our empathy really affects our own mental state. So it's very important for us to also work with our peers, with our teams, and understand that, these boundaries, if we can't cross them, it's not for you to take on that guilt. That's a boundary that the family has placed. It is also by no means a reflection on your capacity as a healthcare provider. So it's difficult. It is difficult. I won't say it's not. You use this word haunts you. Like, I can imagine how much it's impacted you. But I would say, this is also self-care, to learn where these boundaries are. We can't win every battle. So sometimes we just go with the battles that we can pick. Yeah.
So true, ma'am. Mr. Shivkumar was anxious. Would want too much information create more worries?
It really depends on how the information is presented. I wouldn't say give all the information all at once. One of the biggest problems today, I feel, is like there's so much information coming at us. It's like trying to drink water from a hose pipe. You'll choke. So no, giving information requires a certain art, which is why I have said this before. Communication skills, very, very important to upgrade your communication skills on a regular basis as you would do your clinical skills. So yes, too much information all at once will cause more stress. So you have to really pace yourself. If we will talk about that in communications as well. There might come a time when the patient says they want to know, but somewhere down the conversation, they start showing you signs that they don't want to know more. You have to stop. Okay. Yeah. Yes. Anu?
Yeah, so again, the people keep talking about the finances. The problem is in the system, because none of the hospital, they have built any facilities for the home care. If the patient can't come to the hospital, that doesn't mean he don't need the treatment. Everyone is like, you come here, you pay the bill, will serve you. If you want to do it at home, or if you don't have the prices, just go back. So that's a problem, because if you can place one doctor from each hospital for home care, so every patient can get it reviewed every day. The caregiver can be trained for doing the basic things, giving some injections subcutaneously. So many things can be done, but the idea here is lacking the support from the hospital, not from the patient side.
How do we get to work with you, Anup? Because you're completely in line with how we think of the system as well. So there are efforts underway to integrate palliative care with primary health. So if this is something that ignites your passion, let's have more conversations about that, because I think more people like you need to be involved in this. So,
yeah, we are getting lots of help from the Pallium India. Now the Mr. Rajendra, who's take care of North India. So with him, we are the first one who's registering our palliative care center, and we are the first one who's trying to provide narcotics to Pan India for patients. So we are the first one who creating that portal, so that this problem will be sorted out, because in the whole North India, the methadone is only available in AIMS. So that's something. When I heard it, I was like, nee, we have to take care of that. If something is required, need to be delivered. So same way, the Pallium is helping us a lot. They are the one who's talking to the ministry. They are the one who's guiding us how to get the license, how to get the centralized license for India. So already you people are doing lots of things.
Fantastic. So I'm glad to hear this. Thanks, Anup. Thanks a lot. Thank you very much. I just saw a very poignant message from Abhilash. Thank you for that message, Abhilash. And if there's any way we can support you,
Correct.
we will.
Just
Okay.
remember, not only Abhilash, everyone over here, that is what we are here for at Pallium. Whenever you need a supporting hand, whenever you feel that you need just a push to move forward, because everyone faces this difficulty to take that one step ahead in your life's journey. Right, ma'am?
Absolutely. I'm very concerned because we have a case presentation.
Ma'am, actually, we did have a very relevant case, but since the time is not enough to discuss the case in detail, we thought that we will postpone it, because
Okay. That makes sense. I think there's also a very robust conversation going on here. There's a question about cannabis. Okay, so cannabis is being used extensively in different parts of the country and abroad for pain. I would say that there are certain kinds of pain where it can help. There are certain kinds of pain where it absolutely cannot by itself help, where it needs to be an adjuvant to other painkillers. So cannabis cannot be seen as a standalone gold standard pain reliever. Okay. Morphine is the gold standard for pain relief. There are certain, I would say, I don't know, maybe I'm getting the statistic wrong, but there's a certain percentage of cancers that don't respond, like bone cancers and things that don't respond to morphine, in which case, like Anup just talked about methadone. Methadone can be used. It's a little bit more complex, but it can be used. But I would say that, yes, cannabis has its place, but it cannot be seen as the only way to treat cancer, because also it depends on certain things. For some people, if there is, depending on THC in cannabis can also cause anxiety. THC in cannabis, not everybody is going to be calm after taking cannabis. For some people, it actually causes a little bit of restlessness and things like that. So it has to be taken under supervision, careful supervision, and as an adjuvant rather than a standalone sort of treatment option. But again, I feel like an imposter saying all of these things when I know there are doctors in this group, so who are still yet to speak up. But if anyone has any other opinions, please, you're welcome to share them.
So, like as the cannabis works, the THC will increase your all the sensation in the body. So I think even in the pain, if you give it, in some of the pain will be aggravated. The patient will start feeling it with the more intensity. The THC and cannabis will be more helpful for dealing with the nausea, dealing with the mood swings and all these things. It will calm your brain, it will calm your body, it will improve your appetite. You start enjoying the food, you start have a good feeling about things. But if the same situation, if you are in severe pain, so the pain intensity will also increase with this drug. So that's my experience with this. I have tried this one or two patients. So it didn't help much in the pain, but some patients it got aggravated because it increased the pain sensation also.
Thank you. Yeah. So there, I think you have your answer.
I think we covered all the questions that were parked in the chat. Anyone else would like to, any burning questions? Any valuable comments?
Can we have some cameras on, please? I'm a little scared that people are asleep also.
The phone might be grieving, Mr. Shivakumar. Need not be necessarily depressed.
Yeah. All right. I think it's important in our sessions because we are focusing on a human connection. It's nice to have cameras on, okay? Because otherwise we're talking to a bunch of tiles on the screen, and then it's a little bit, like I said, dehumanizing. Any final reflections, comments, questions? I think I've set a record for myself, Shri, by finishing 4 minutes early.
Congrats to you.
All right. If any questions emerge later, you're very welcome to send them across to me. I'm happy to answer any other questions that you might have. And yeah, look after yourselves. Keep those mental health scores above. And see you at our next session, whenever that is. Thank you.
Thank you, Smriti ma'am. We know that you are not even half through your day. Having personally known you for some time now, I know that your work actually is only halfway through, and still you found out time to interact with us, to share your experiences with us. Thank you so much for that. And thank you each and every participant, especially for sharing your personal experiences, for trusting us with them. Thank you, everyone. And we do hope that all the lessons you learned from here make you better human beings, make you better caregivers in coming life. So, with that note, this is Sripriya along with Mr. Sangeet signing off from the Tips Echo, along with Ms. Smriti Rana. Till we meet again, take care everyone. Keep spreading happiness. Bye bye.